Okay, let's jump right into this explainer. We're unpacking one of the most feared, yet honestly incredibly fascinating complications in all of organ and stem cell transplantation, PTLD. We're going to break down exactly what happens when the literal life-saving act of a transplant opens the door to a really complex and sometimes deadly cellular rebellion.
Picture this. You've got a patient who just underwent a totally successful kidney transplant. I mean, the surgery was flawless, the organ is working perfectly, and they're sent home on standard immunosuppressive therapy. But a few months later, they're back. They've suddenly developed a persistent fever, swollen lymph nodes, really severe weight loss, and a rapidly enlarging abdominal mass. So, you've got to ask yourself, are we looking at a bizarre infection here? Could it be graft rejection? Or is it cancer? What exactly are we dealing with?
Well, the answer to our mystery case is PTLD. And the absolute crucial point of grasp here is that PTLD isn't just one single disease. It actually represents an entire spectrum of abnormal lymphoid proliferations. Clinically, we classify this spectrum into four main buckets. You've got non-destructive hyperplasias, polymorphic PTLD, monomorphic PTLD, which includes those really aggressive diffuse large B-cell lymphomas, and finally, the rare classical Hodgkin lymphoma-like PTLD. And in the vast majority of cases across this whole spectrum, the puppet master pulling the strings is the Epstein-Barr virus, just totally taking advantage of a weakened immune system.
To help you master this condition for the wards or your board exams, we're going to structure this explainer like a complete clinical workup. So we'll hit pathophysiology, risk factors, clinical features, diagnosis, and finally treatment.
All right, part one. Let's get into the pathophysiology.
So normally, your cytotoxic T cells, they act like cellular security guards, right? They're continuously suppressing any EBV-infected B cells. But after a transplant, your patients require these life-saving immunosuppressive drugs. We're talking tacrolimus or cyclosporin. And this effectively knocks out those protective T cells. Without that critical surveillance, the Epstein-Barr virus either reactivates or establishes a primary infection. And that just unleashes this uncontrolled B-cell proliferation. And as you can guess, that can eventually transform into those malignant lymphomas we just talked about.
Moving right along to part two, risk factors.
Okay, pay attention to this stark contrast because it's a massive high-yield exam pearl. The absolute highest risk scenario you'll see is an EBV-naive or seronegative recipient getting an organ from an EBV seropositive donor. It is the classic D-positive, R-negative mismatch. Think about it. You're essentially introducing the virus into a body that has zero pre-existing immunity, right at the exact moment you are medically suppressing their entire immune system. It's a perfect storm.
Now, the risk also heavily depends on the specific organ being transplanted. Intestinal, multivisceral, and lung transplants carry a much higher risk compared to, say, kidney transplants. Why? Because those organs just require heavier immunosuppression, and they carry a larger load of donor lymphoid tissue with them. Pediatric patients are also at a much higher risk, simply because kids haven't lived long enough to encounter EBV naturally, so they lack that prior immunity. Oh, and finally, using intense T-cell depleting induction therapies, like anti-thymocyte globulin, that massively shoots the risk up.
Okay, section 3, clinical features.
The tricky part here is that the symptoms are just notoriously nonspecific. Honestly, it often masquerades as a typical run-of-the-mill infection. You've really got to look out for constitutional signs, unexplained fevers, night sweats, profound fatigue, and significant weight loss. Alongside all that, check the patient for painless, generalized swollen lymph nodes. But here is where it gets incredibly dangerous. PTLD very frequently involves extranodal disease. It can invade the GI tract and cause severe bleeding. It can jump to the central nervous system and trigger seizures. And tragically, it can even directly attack the newly transplanted graft itself, causing that organ's function to just rapidly tank.
Which brings us to part 4, diagnosis.
All right, lock this absolute gold standard fact into your brain. You must, absolutely must, obtain a tissue biopsy. Ideally, an excisional biopsy of the involved tissue. You just cannot diagnose PTLD purely on clinical suspicion or some blood work. A pathologist actually needs to look at that tissue under a microscope. They have to confirm the morphology, they need to check for clonality, and they have to test the EBV status directly inside those cells. Now, while you're arranging for that biopsy, you're going to support your diagnosis and stage the disease using a couple of other tools. You'll want to run a quantitative EBV PCR. Now, just having EBV DNA floating in the blood doesn't definitively equal PTLD, but it is fantastic for risk stratification and for monitoring how well your patient is responding to treatment down the line. And for staging, a PET CT scan is basically your best friend here. It lights up the metabolic activity of the disease, which lets you accurately pinpoint any extranodal involvement, whether it's hiding out in the lungs, the liver, or the graft itself.
Finally, part 5, let's talk treatment. So treatment is a really precise escalation. Step 1, you almost always start by carefully, and I mean carefully, reducing the patient's immunosuppression. You want to wake up those suppressed T cells so they can fight off the EBV and those abnormal B cells. But obviously, balance is key here because you definitely don't want to trigger organ rejection. Step 2, for CD20-positive B-cell PTLD, we bring in rituximab. It's a targeted monoclonal antibody that just wipes out B cells, and honestly, a lot of patients respond beautifully to this alone. If the disease is more aggressive or it's just not responding, we graduate to step 3, which is R-COP chemotherapy. And finally, for those really stubborn refractory cases, we start looking at advanced therapies like CAR T cells.
Okay, let's set up a quick memory anchor for the boards. You can literally use the letters in PTLD to lock down the core mechanism. P stands for post-transplant. T reminds you that the root cause is T-cell suppression. L is the result, lymphoid proliferation. And D is to remember it's driven, commonly, by EBV. It's just a beautifully simple way to recall exactly what's happening on a cellular level.
And guess what? We can do the exact same thing with the letters EBV to remember the cellular drivers of the disease. E is for the excess B-cell proliferation that happens without that T-cell oversight. B reminds you that the end result is very often a B-cell lymphoma. And V stands for the viral reactivation, or primary infection, that kicked off the entire disaster in the first place. Keep those 2 acronyms in your back pocket, and you absolutely will not forget the pathophysiology.
All right, let's do a rapid review of your absolute high-yield facts. The main cause? Always post-transplant immunosuppression. The major virus? Epstein-Barr virus. The specific cells involved are predominantly your B lymphocytes. Now remember, the absolute highest risk scenario is that D-positive to R-negative EBV mismatch. And your crucial go-to first-line treatment? Always look to carefully reduce the immunosuppression.
You know, early recognition and carefully stepping down that immunosuppression have totally transformed and dramatically improved outcomes for this deeply feared complication. It really highlights the ultimate paradox of transplant medicine, doesn't it? The very same drugs required to give a patient a second chance at life can simultaneously pave the way for a deadly cellular rebellion. So what complex medical mystery should we dive into next? Let us know. And thanks so much for joining this explainer.